So I have the opportunity to do this last session before we get ready for lunch. So my discussion today is really going to be focusing on food insecurity in the clinical spaces. Thinking about how you can approach this topic in clinical spaces, how you can approach it in the work you all doing in your programmatic spaces, and really making this more and more practical, and building off of what Dr. Leung and Ms. Washington have done such a great job in setting the groundwork around. So, my name is Dr. Kofi Essel. A little quick introduction. I'm not going to read a bio, but I am Director of Culinary Medicine Program at GW. I also do a ton of work in the food insecurity and obesity arenas, and do a lot of work on early child feeding, obesity stigma, and really excited to talk to you all today. Let's go ahead and dive in. So, I have nothing to disclose. We're going to start with our roadmap, a few things that I want to make sure we do today. First and foremost, we'll start with the background, really laying out some of this background we've been talking about, building off of, again, what Dr. Leung and Ms. Washington have already laid out. We're going to go next to talking about screening. How do you screen? What does it look like? What are screening tools that you can use in your workspaces, in the clinics, in your programming? And then we'll talk about intervening. How do you address food insecurity? You never want to screen unless you're going to intervene. So we're going to talk about ways in which we can address food insecurity. And lastly, we'll talk a little bit about food as medicine as an approach to addressing food insecurity. You'll hear two different ways of saying that. Food is medicine, food as medicine. I don't really fall in either camp. I probably just picked as because it was the first one to come to my mind today. So let's go ahead and dive in. So where does this all start? This starts here. Sudden financial hardship that a family runs into, right? Food insecurity, right? A sudden financial hardship a family runs into. And that starts a cascade of events that then a family has to endure. These coping mechanisms are these events that a family then has to endure. Why, when a family has a financial hardship, does food end up being the first thing to drop? Why? Because that food budget is very flexible, it's very fungible. So as a result of that food ends up being the first thing to drop. Let's look at what Dr. Leung was saying and really sort of lay this out in trajectory order. First thing families tell me when they say, hey, we're experiencing food insecurity, we have this sort of event that's happened, this financial hardship. First thing families often tell me is this concept of food anxiety. This concept of perseveration, preoccupation with where one's next meal is going to come from. Dr. Leung talked about this idea of this stressor on people's minds, on their hearts, on their souls, right? This idea of a toxic stressor, what some of us describe it as it decreases one's cognitive bandwidth. The ability to shift and focus on many things becomes hindered because of this toxic stressor. After that occurs, as Dr. Leung did so well, what ends up happening is the quality of the diet begins to decrease, right? We talked about this concept when stressors hit, we sort of gravitate towards foods that are highly palatable, higher in sugar, higher in fat, more processed foods. In addition, if you think about the situation in the home, I also don't want to waste my food. So I want to pay for food that I know my family's going to eat. If I buy foods that they're not going to eat, then what is going to happen, right? They're going to waste that food. It's going to increase the stress in the home. I'm going to simplify my foods, reduce the variety, reduce the nutritional value, increase the caloric density. Why? Because of all of these other aspects that occur. So that's something you tend to see next. The quality of the food tends to change. After the quality drops, of course, the next thing that happens is the quantity of food drops. Who's going to drop first? As Dr. Leung mentioned, adults will do everything they can to protect their children. And lastly, at the end, children's food intake begins to drop. When the quantity drops in food in children, we know we're dealing with more of an extreme. But even in that case, the palpable and toxic effects of food insecurity are felt throughout this whole journey for a family. Now, as Dr. Leung mentioned, we think parents feel like they're buffering their children from food insecurity. But the reality is children know what's going on. In fact, some children actually eat less so that their younger siblings can eat more, coping themselves to really help and support their households as well. So we've talked a lot about this concept, this journey for families who experience food insecurity. We see here this idea of the quantity and the quality dropping. But what would happen if instead of just focusing down here on the quantity, we went upstream and began to focus on the quality of food? I haven't used this word yet, but I mentioned it earlier. Therein lies the definition of nutrition security. Instead of focusing on strictly the quantity of food, we're going to be focusing on the quality as well. Look at USDA definition. Nutrition security means consistent access, availability, and affordability of nutritious foods and beverages that promote well-being, that prevent disease, and if needed, treat disease. Think about your role in culinary medicine. I hope you can see yourself up here, right? This is your role in addressing food insecurity, transitioning, understanding, and addressing nutrition security, the nutrition-related chronic disease, as well as these other factors. Really important. One part of the definition I left off that I think you need to understand and really, really hyper-focus on is this deeper layer of nutrition security definition by the USDA, particularly among racial and ethnic minoritized populations, lower-income populations, and rural remote populations, including tribal communities and insular areas. We recognize that in addressing food insecurity, in addressing nutrition security, we're talking about marginalization. We're talking about not only racial ethnic marginalization, but insular areas. We're talking about regional differences. We're talking about all these other things that we tend not to talk about. These are important. So with the definition of nutrition security, yes, we think about food security. Yes, we think about the quality of food, but we also need to make sure we think about equity. Equity is core to this work. We cannot address nutrition security unless we're also thinking about equity in our approaches to doing this work. So what we do today is trying to figure out how we can go strictly from here over to nutrition security. In culinary medicine, there's something I like to say. Culinary medicine must proceed with intentionality, focus, and advocacy to not worsen disparities. We cannot just focus on those who are food secure. All we're going to do in that way is going to worsen disparities. Right? We're gaining all this new knowledge, this new learning that we're gaining, and then we just go and teach those who already have all of the food security. That's great. People are learning, but we have to remember in our approaches to doing this work, we need to be thinking more globally and more holistically about nutrition security. Thereby, culinary medicine can serve as a catalyst to advance our conversation from food security to nutrition security. And again, I hope you see yourselves up there as we're talking today. One last image I want to really highlight today is this concept. And anybody heard of Ellen Satter? Everybody's favorite dietitian, Ellen Satter. So she has a wonderful sort of overlay she does. She overlays Maslow's hierarchy, right, our needs with food insecurity. And this is sort of what she overlaid in an interesting paper. You can see here the baseline, what everybody is trying to achieve. The families who are experiencing food insecurity oftentimes are trying to achieve getting enough food, right? The idea of novel food, that quinoa and kale bowl that you're trying to give your family to introduce to them. Sometimes that's higher upstream, right? The idea of getting the palate used to that quinoa and kale bowl is interesting. Think about it. What do we usually say? Your palate is malleable. If you keep trying it, you'll adjust to that food. But if I eat that food, I don't like it, and I waste that food, what kind of stress does that bring inside of me? Right? So again, the idea is, are we asking our families to meet us where we are, or are we meeting our families where they are? Right? The idea of culinary medicine is important to make sure we're meeting our families where they are and walking with them on this journey. And I know Sabrina, in the movie tomorrow, we're going to be talking more about that as well. So this is a really important image to be thinking about, right? Families at the baseline are trying to get enough food. You keep moving forward and walking with them on that journey, which is what we do in culinary medicine. It's not a one-stop shop. We're going on a journey together, and you're able to continue to do this alongside of each other. So what I want to do right now is talk about some images, some pictures that have come up over the past. So in 2020, September 2020, Brenda Ann Culinary, if anybody may have seen this in the New York Times, it's a wonderful expose talking about, she's a photographer with the New York Times. She went around the country and looked at people's lived experiences with food insecurity. Went to different homes, had a lot of good conversations, and came across a lot of beautiful pictures that really tell a story of what families experience. If you haven't seen this, check it out. If you don't have New York Times, you get like a free one time a month or something, so you can check it out. Make sure to look at these images here, and I'll show you now. So, first image I want to show you is here. Here's a family around a table, very thankful for their food, but look on the table. What foods do you see? Foods that are more processed, right? Highly palatable. I'm not going to waste these foods. The families, they smile when they enjoy these foods, right? That dopaminergic release that occurs with these foods. This is interesting. This is important. This is what families oftentimes are purchasing because, again, we're talking about the quality of food changing. We can see another picture here, the dearth of food that exists in some individuals' refrigerator. Right? This is something you see as well. You can see here a family preparing food, canned, boxed, foods that are going to last and are not going to waste. If I buy that produce, what's going to happen? It may go bad quickly. I don't know if I want to invest in that time. Right? Thinking about that concept, I think, is really important as we think about how we address this in culinary medicine. Here's another picture here. A lot of butter, a lot of milk, right? Again, highly palatable, right? Caloric density increases, filling us up, giving us that smile. That's something that people often talk about. Here's one last picture I want to show here. Another family really thankful for the food that they have. What value do we put on food in our culture? What value do our patients and our families and our clients put on the food that they consume? Thinking about that is really important. If I am dealing with a lot of toxic stressors, social stressors, food is oftentimes really easy to use as a tool to increase the excitement in my home. Although temporary, increases the joy. I get to feel good as a parent or caretaker of my child. They smiled. They said thank you. They gave me a big hug. There are a variety of other things I can't control, but this is one thing that I can, so I'm going to do that, doctor. I'm going to do that, nurse. I'm going to do that, chef. It's an important thing to keep in mind. Now, this last picture I'm going to show you is the most important, consistent picture that you will see when we think about households that are experiencing food insecurity. By far, this is the picture that you're going to see no matter what. Nothing. Food insecurity is often described as being invisible. We cannot consistently rely upon laboratory exams, physical exam findings, anthropometric changes, weight loss, weight gain. These things aren't going to tell you the story. They're unreliable. They're not consistent. But unfortunately, we use them to determine if a family is struggling. When I've asked this question to my colleagues around the country, what they tell me is the main sign they look for. What do you think is the main sign that they look for? The main sign that people look for food insecurity. What do you think that is? Malnutrition, which is oftentimes people describe as weight loss. They haven't lost any weight, everything's fine. Right? And as Dr. Lung mentioned, there are overlays that people talk about with increased weight gain. But it's also, the data's all over the place with that. You can't be reliant on these things to be able to determine it. And all that's really doing is you're waiting for your own biases before you then intervene. Oh, they look like they're fine. I'm not going to ask any questions. When I talk to my colleagues around the country, when they start to do this work in screening, what do they tell me? They say, Doc, I didn't know it was going on like this. I would have never guessed that this family was experiencing food insecurity. Look what they're wearing. Look what they're coming in with. They have brand new socks. They have a brand new shirt. The tag's still on their shirt. They're bringing their best to you to protect themselves. And that's an important thing to remember. So, 2011 is when I started getting into this work in food insecurity. I came across this term. It's my last year in medical school. I'm ashamed to say we weren't using this term at all. I hadn't even heard of this term. Not to say I didn't have lived experiences with it, but I'd never had heard of the term of food insecurity. It was a new term to me, and I wanted to understand what this was really about. And I promised myself that my students are going to all know about this because they need to understand how prevalent, how ubiquitous food insecurity is. You saw the map that Dr. Lung put up there. Food insecurity is ubiquitous. It exists in every single county around this country. You cannot hide from it. The question is, do you want to continue to act like it doesn't exist? Or bring it to your attention and actually work with your families in addressing it more effectively through the lens and the power of culinary medicine. In 2015, something special happened. 2015, the American Academy of Pediatrics, and again, as a pediatrician, we were one of the leaders in this, which pediatricians usually are. I'm just kidding. Just kidding. So we were one of the leaders in this. They put out a groundbreaking policy statement. What did it say? It said that providers across the country should do a few things. One, screen and intervene to address food insecurity universally. Not just when you see some sign, not when you see signs of poverty, not when you look at somebody like, oh, they're on Medicaid, they must be struggling. Let me ask them questions. Universally, because why? The visibility of food insecurity. You cannot rely on that. Number two, they said, hey, let's go upstream. Let's get outside the four walls of our clinical settings and advocate to end childhood hunger. Bringing these worlds together are important in recognizing the power of each and every one of your voices. When you're able to see what you're seeing, when you're able to work alongside your families, and letting those voices come to life, bringing those voices to the table, allowing those voices to really make noise is critically important. In addition, you have a voice too. And you get to use that voice to advocate for your families as well. And that's important to keep in mind. So we created a toolkit in 2017 using what we learned from the professional, that statement that came out. This is our most updated toolkit. Check it out. You can check it out online. Came together with the Food Research and Action Center, one of the premier anti-hunger organizations in the country, and the American Academy of Pediatrics. Put all these pieces together and created this wonderful, beautiful toolkit. This is the most updated version of this toolkit. And it really breaks down a few things in particular. And this is what it's going to really talk about, and I'm going to spend our next remaining minutes talking about these steps. How do we prepare? How do we screen? And then how do we intervene? I start with prepare. I don't start with screening. Because if you just start screening and you haven't prepared, you're setting yourself up for failure. It's important to prepare first before we move into these next steps. So let's start with preparation. Prior planning prevents poor performance. Anybody used to hear that? Right? Love it. Prior planning prevents poor performance. A lot of you may have done this work, and maybe some of you are screening already, and you know how this is. You've gotten this great work you've done, and you said, hey, you know what? I created this wonderful list. I got all these names and all these resources, 30, 40, 50 items. I'm just going to give it to my family. And maybe you gave it to your family, and what did you notice? You left the room. You felt good about yourself. You walked back in the room, and what did you see? That piece of paper didn't leave the room. Sometimes it doesn't even make it in the trash can. Sometimes it's at the elevator on the way out. Sometimes it's in the parking lot. That piece of paper is a cold document. Sometimes there's no connection with it. Right? So it's a great start, but we can do this better. I love what Dr. Earl said out of North Carolina. She said, don't start screening today if you haven't made a plan for how you talk to families and how you can link them with support. Ideally, be able to link families using a warm handoff, not just handing them a resource list. Right? That resource list is cold. Can we warm that list up before we provide it to families? Something we want to consider in doing this work. Here's some quick tips to prepare. The first thing that I usually recommend is identifying a hunger champion in your clinical spaces, in your programming spaces. Does it have to be you? No, it doesn't. It could be an individual's lived experiences of hunger in your clinical workspaces. These are opportunities to really get people involved. Somebody whose voice is able to be heard and brings it back to the table so we don't forget about the importance of addressing this work. So identifying a hunger champion is number one. Number two, train your staff and leadership about food insecurity. Again, when we prepare, we don't want to just do this. We want to really set the groundwork. How serious, how important is food insecurity? Training your teams are critically important in doing this work. Number three, universal screening. Not just when we stigmatize or have these biases towards our patients. We do this for all of our patients. I don't care the income bracket, because you never know what families are experiencing. There are ways to do that to help buffer it a bit if you want. We can talk about that. But in general, universal screening is key. And lastly, I want to say this. Practice normalizing the questions. We ask this question to all of our families and then go into it. Right? Really important. So one last thing I want to highlight is, I think, the important pieces about doing this work. Some of you may be sort of cringing in your seats and saying, like, how am I going to ask my family about this? Isn't it too intrusive? Aren't they going to be worried? You're right. It can be a very sensitive question. But it's important that when we do this work, we provide a lot of dignity, create a safe environment for our families so this is not blowing this up, so it's not stressing our families even more, so it's not re-traumatizing our families. How do we do this? Let me tell you an interesting study that came out in one of our premier journals in pediatrics. So one of the teams went out into a suburban community and said, hey, let's start screening for the first time. Suburban communities, oftentimes people describe as Disney World, right? No poverty, no stress, everything is great. But of course, if you gaze more into what's going on in every community, you see food insecurity existing. So as they're screening for food insecurity, they noticed something really interesting. There's a lot of powerful quotes from clinicians and families. One quote in particular that one family said is this. I was really kind of shocked because when the doctor did ask me, I was struggling at the time. I didn't want to lie, but I didn't want to be completely honest because I didn't want her to think I was neglecting my child. Neglect. Child Protective Services. Are you going to call them on me? What if I tell you honestly what's going on? Are you going to give me up? Are you going to take my child away from me? I can't risk that. I can't tell you the truth, doctor. I'm going to hold this to myself. To do this work well, we provide dignity, we provide privacy, we provide intimacy, and we're able to do this work incredibly well. Our next area we're going to talk about is screening. Why do we screen? Because food insecurity is often described as being invisible. You need to screen to be able to identify it effectively. So screening is critically important. So there are a variety of screeners out there. Some of you may have seen. There's comprehensive screeners that ask you about transportation, housing, bills, utilities, all these things. But if you don't have the resources to support families, don't ask the questions. Right? If you don't have those resources, don't ask the questions. If you're starting to do social determinant screeners, food insecurity is a great way to start. Why? Because there are great resources that are in place in every community that we can really support our families around. So it's important to think about that. So with all these screeners out there, there's even some different hunger screeners out there. But one of the tools that I heavily emphasize is the hunger vital sign. It's a 2-question, easy-to-use screener that fits easily into one's workflow. Easily fits into one's workflow. You can ask these questions, get a good sense of if the family is at risk for food insecurity or not. So there's a gold standard questionnaire that the USDA does every year. They ask about 40,000 people around the country. They ask them their food insecurity status, and this is what allows us to see how serious one's food insecurity is in the household, as Cindy mentioned on the slide when she gave her presentation. But what we've learned is that these first 2 questions have high sensitivity and specificity. Really effective. They do a good job in addressing or determining if a family is at risk. It doesn't tell you the degree of food insecurity going on, but it just tells you, hey, this is going on. Their family's at risk. Maybe we should be supporting or working alongside our family in this moment in time. And so that's something important to think about. What are these 2 questions? How do they sound? Let's read them out. So question number 1. Within the past 12 months, we worried whether our food would run out before we got money to buy more. Question number 2. Within the past 12 months, the food that we bought just didn't last, and we didn't have money to get more. Yes or no? Yes or no? That sounds easy. Yes or no? When people started using these questions at first, they threw in these questions of the response variable, the dichotomous response variable of yes or no. The reality is, if you're using this variable, it's not the best thing to use. In fact, the real questionnaire used this variable. Often true, sometimes true, or never true. And I would even argue it's important to put that 4th variable is, I don't want to answer your question. I prefer not to answer. Giving them that autonomy, putting the power back in their hands. Really important, right? So these 2 questions are really great. You see yes or no versus this. Is one better than the other? Does it matter? Is one really better than the other? Let's look at a wonderful study by McClarsky et al. So this first variable, the dichotomous variable, yes or no versus this 4-point Likert scale that we see here. Which one is better? That's the question that we're going to ask today. Well, what we noticed in this study was something really interesting. When we asked these 2-question response, or yes or no rather, what did we see? We saw something really interesting. What did we see? We saw that more than 25% of families were missed who were experiencing food insecurity by doing a 2-question response variable versus this Likert scale. What do you think was the answer that people chose the most in the Likert scale? Have y'all seen this presentation before? So yeah, sometimes true. You get it, right? Because, hey, doc, this happened like a long time ago. Is there anything that you can provide? So this is something that helps to buffer. It's a scapegoat answer. It's a way of somebody saying this happened a while ago. It's not to say that this is sometimes true. It creates an environment, a safe space for the family to do it this way. So that's what we tend to recommend above them all. So considering that. The second thing people often ask me is, how do I ask these questions? Do I say it to them? Do I write it down? Do I give it to them on a written variable or tool? Well, that's a really important question, and we're going to address that. We say doing these questions, and something I didn't highlight, I apologize, is if one or both of these questions are sometimes true or often true, that is a positive response, right? So we do not recommend yes or no. We recommend often true, sometimes true, never true. If often true or sometimes true for one or both, it's a positive response. All right, so let's talk about this paper piece. So what we saw in some interesting data that used the yes or no variable, right? So it didn't even get the high responses that they would have gotten if they used often true, sometimes true, or never true. They saw a statistically significant increased response, positive response, when they used the written version versus using a verbal version. We all have our own quirks, right? When we ask it, we take shortcuts with our questions. We say, oh, are you hungry? Are you dealing with any challenges with food? Like, we just ask it in different ways. And it's uncomfortable to ask that question verbally, and it's also uncomfortable for the family to respond verbally. So we encourage you to do it through a written kiosk, having a laminated piece of paper, something to protect the family, and do it in that kind of way versus verbally asking them. That's going to be your best response when you do it in that kind of way, and that's something to keep in mind as well. All right, so when you screen for food insecurity identified in clinic, one of the things that we recommend is putting in your notes, right? So we have a Z code for that you can use as well, Z59.41. Right? There are a lot of other social determinant screener or Z codes that have been added to the list because we recognize that addressing social determinants or recognizing social determinants is good healthcare. Right? It's part of what we do. It's important for healthcare as a whole to think about this. So our last section we're going to talk about is intervening. How do we intervene effectively? What does that look like to address food insecurity effectively? And we talked about a lot of really powerful tools today with Ms. Washington especially. One of the things that I like to focus on, especially when you think about one's cognitive bandwidth, right? If I'm always focusing on where the next meal is going to come from, maybe having a little bit of structural support may be really important. One of the things that we often talk about is the role of federal nutrition programs. Do they play a role? Can they be supported for families? We see time and time again that federal nutrition programs are evidence-based and effective in reducing food insecurity, reducing poverty, improving overall health outcomes, reducing hospitalization rates. We see that they can stimulate the local economy. They have a purpose. They have a plan. Sometimes families just need it for a short period of time. And that's something that we can encourage when families want to use them, right? Giving the power back to them. Do you want it or not? Families sometimes don't want to for a variety of reasons. So typically when I think about my cogs in the wheel, the structure that I think about, the first thing we talk about is addressing the anchor, the federal nutrition programs. That is, a lot of families, about 50% of families who are eligible for example, the SNAP program, the food stamp program for those who don't know that name, SNAP. 50% of families actually don't use it, again, for a variety of reasons. And that's one of the anchors that I start with. So SNAP is a great program. As a pediatrician, we talk about school meals, summer meals programs. There's child and adult care meals. There's so many great programs out there that families can be supported around that I think about. After I think about those programs, I also start to think about some of these other programs, emergency programs and ancillary programs as needed and beneficial for families. But as Ms. Washington says, we're trying to put that power back in the family's hands. So recognizing, hey, there are options out there. What does your family want? What are they interested in? What works with them? Now, we talked a lot about seeds earlier. But guess what? With SNAP, you can actually buy seeds for your household. When you are using your food stamp EBT card, you can use that to purchase seeds, to plant, to grow more food for your family as well. That's one of the things you can do there, as well as something that people often don't know about. So I think there's a lot of different approaches here to think about. When you think of emergency food, you think about food pantries, food banks, right? Food banks, large, provide food, oftentimes to food pantries, right? Small, right? We think about community gardens. We think about all these other resources that are really beneficial and staples to communities. Critically important. All right. So the last thing I want to talk about is really important. And this piece here is thinking about how you prepare. We want to train our team to make sure that they understand what the federal nutrition programs are, what the local programs are that can be beneficial for them. We want to determine who in the practice can facilitate that connection. It doesn't always need to be you, right? It doesn't need to always be the instructor, the leader, the professor, right? You can think about other team members on your team. Again, think about this as a collaborative effort. And the last way to think about this as collaborative is working alongside your community partners, right? Stop trying to put all this on your own shoulders. Our community partners are critically important. They're part of healthcare right now, right? With ACO, we recognize them as part of healthcare. So in doing that, working alongside our partners, we say, hey, I don't know how to teach my team and my staff about this. Hey, can you come and talk to our team about this? Can you empower us to be able to direct people towards you? What does that look like? Every state has anti-hunger programs that you can work with, right? You can check them out. A lot of states, you can just call them up. Food banks, some of the pantries will help. A lot of different organizations. In D.C., we have D.C. Hunger Solutions, which is a phenomenal organization. There's so many different programs that are around us that we can tap into. And I want you to keep that in mind. How can you work alongside your community partners? The last step with intervening is, of course, advocating. Recognizing that we need to advocate and educate to address food insecurity and its root causes. Poverty, inadequate wages, housing security, and structural racism. Thinking about this piece is critically important. Food is not the only solution to food insecurity. In fact, sometimes it feels like a Band-Aid. Sometimes. We got to think about this at the core. How we can make sure that we think about what are these other root causes that lead to food insecurity, and how can we use our voices to address this. Now, I put this slide up here because I think it's important. A lot of times when we're doing this work, we're saying, oh, we're addressing social determinants of health. We're doing that. We're addressing social determinants of health. You providing food to a family is not addressing social determinants of health. You're addressing a social need, right? The social need that a family has is voice, that they need that. The social risk of food insecurity, social determinant, thinking about more of that root cause. But we can do that. And we do that not from the clinic, but by stepping outside of the kitchen, of the clinic, to use our voices to impact at a greater level. And that's important. So here are some advocacy actions that I would recommend that you consider. And why do I say this? Because some people, a lot of my colleagues, my students say, where do we start? How do we really use our voices powerfully? Well, here's some ways I want you to think about. We're just going to put a few up here so you can kind of see them. The last one that I have up here, number 10, is one that we often start with, educating the next generation, right? Who is the next generation? Who can you pass that message down to so that they can continue this work as well? That's critically important. Using your voice on op-eds, right? Talking to your local congressperson, really important. Blogs, letters to the editors, these are really important. Taking the SNAP challenge, living on the SNAP budget for a period of time. When my students do this, they tell me all the time, I couldn't think about anything else. I was just thinking about food all the time. What do you think your families are doing? One of the things that I saw with Dr. Lung's presentation is this idea of numbing, right? When that child has gone hungry for a few days, they get numb to it. When that parent has gone hungry for a few days, they get numb to it. This is what happens with these toxic stressors. They just wear at you and wear at you and wear at you. How can we be supportive to our families? It's really important to think about these. So these are some actions to keep in mind as you're thinking about how do you better advocate. So let's make this all practical, and we'll end this conversation today. How do we make this all practical? With healthcare, what are we trying to do in healthcare? One of the things that we're trying to do is move from this idea of just fee for service, right? This idea of you do something and I get paid, right? Because that model may not be the best model. So how do we think about this in a more global way? How do we think about that? And one of the ways we do this is through the idea of the triple aim. Anybody heard of the triple aim in the room? Triple aim. All right, so I see a few hands. Triple aim looks like this. First thing we're trying to do with triple aim, we're going to improve population health. This is one aim, three different dimensions of the same aim. We're going to improve population health. That's what we're trying to do in healthcare. Number two, we want to lower the cost of care, right? Just because we're trying to improve population health, we don't have an unlimited budget. So we want to think about how we can lower the cost of care. And lastly, we want to improve the quality of care and the patient experience. But unfortunately, food insecurity does the exact opposite to this. We know that food insecurity actually worsens population health as a social determinant of health. We know that food insecurity doesn't lower the cost of care, but it increases the cost of care. $53 billion each year are wasted as a result of food insecurity. When a family experiences food insecurity, they're 46% more likely to be a high-cost user in the healthcare system within 5 years. A high-cost user, top 5% user. We know these associations are rich. And lastly, we know that food insecurity doesn't improve the quality of care or the patient experience. It actually worsens it. Why? Talk about trade-offs. I oftentimes will have to buy or purchase my utilities versus eating. I will buy less food or buy different kind of food because I need to get utilities. I oftentimes will let this bill go for a month, come back to it next month so I can eat, right? Do I want to breathe or eat? This medication here, this nebulizer machine costs more money. Do I need to get the food for my family? Should I make sure my child can breathe? Right? That's the concept that comes up often as well. So in doing this, we have to recognize that in addressing this well, we're addressing the triple aim. So practically in your clinical spaces, in your kitchens, in the places that you're working, this is how you can do it. I would suggest starting with a primer question on your screener. Here's one. Our clinic asks every family about the food that they have at home because it is an important part of your family's health. We use these questions to provide useful resources for families if interested. I will then say, make sure you ask them if they want to receive resources. They may say, this choice, this yes or no or often true, sometimes true, never true is never true. But I still may want resources. Why is that? Again, the goal of screening is not to get a positive response. It's to build trust. So in the future, if the family wants to share, you're there. You're open. You have resources in place. So are you interested in food and nutrition resources today or food or nutrition resources today? Yes, no, you prefer not to answer. And the last thing, of course, is asking the hunger vital sign questions. Within the past 12 months, we worried whether our food would run out before we had money to buy more. Within the past 12 months, the food that we bought just didn't last, and we didn't have money to get more. Make sure to add that opt-out option as well. That's a practical way of doing it. Now, when we screen, we need to make sure we what? We intervene. So thinking about food as medicine as an approach to this is a critically important way. You can see this was created out of Massachusetts, of their state plan in addressing food as medicine. You can see at the baseline, thinking about federal nutrition programs, emergency resources, and then kind of going up from there. These are things that you can do to really address both, right? The idea of addressing nutrition-related chronic diseases and food insecurity. Bringing the two together. We can think about prevention, right, with addressing and having these other resources in place, and we can think about being more strategic with medically tailored meals at the very top. Right? My family has diabetes, they have hypertension. I want to make sure I'm using a specific approach to doing that. I'm working alongside a group, and they're able to deliver food to the home that's really tailored towards this. Or me working in culinary medicine, I am creating a certain plan for our family. This is the kind of thing we're thinking about, food as medicine. And then lastly, after you intervene, we need to make sure we do what? Follow up is good. What's the A word? Come on, guys. I'm kidding. Advocate. I love it. I love it. All right. So, reading my mind, right? Advocate. That's the last thing. Using our voice, right? That's critically important. We have to step outside the four walls of our centers, use our voice, and impact this from the top. And that's really important, the work that we're doing. So I want to thank you all for your time today. We have a action-packed afternoon after lunch. We'll be able to come back together. We have a panel ready to go. Please drop off your questions at the desk, and Ms. Hatfield is going to pass them over to us, and we'll be able to use them for our discussion. Thank you all for your time. Oh, Dr. Harlan may have something to say too.